So this is part one of two talks that we're going to be doing this year on return on investment. It is a big topic that we constantly see and hear coming up in terms of things that the public health workforce is interested in and things that the public health workforce largely isn't very confident on, in part because folks like me, folks in academia, haven't done a very good job of training, including incorporating public health, excuse me, incorporating ROI into public health training, and in part because it's kind of a new and a different way of looking at the work that we do. So this session is about assessing and communicating ROI. I'm going to be keeping us at a fairly big picture level today. And I'll talk more about what session two will entail at the end of today's talk, but that'll be more about going not into the weeds, but maybe out of the clouds and sort of down somewhere closer to the ground. And if you want to get into the weeds, love to do that with you. We can geek out about all of the weeds and the microscopic level of detail. But I might save that for something that's not quite so broad. So anyways, without any further ado, so why are we here? Why are we interested in ROI as public health? A lot of us, myself included, were motivated by something approximating this Benjamin Franklin saying, axiom, idiom, whatever, that an ounce of prevention is worth a pound of cure, right? It makes so much sense for us to do public health because an ounce of public health prevention work is worth a pound of clinical cure. That's not to say that clinical cure is bad, just that it is really hard and really expensive to cure something once we have it. It's easier to prevent it. I did want to do a little bit of level setting, though, that Benjamin Franklin wasn't talking about public health when he said this. He was talking about fires and fire prevention. So this is not a picture of Philadelphia burning, but the same general principle applies, right? So it is a good principle, right? But before we get too excited that the ROI value is 1 ounce to 1 pound, and that's exactly the exchange rate that we should be focused on, let's just take a step back and think about this to mean that the relative importance of the two, right? It's really important to do prevention work, but it's not a guarantee that we'll actually see this amount of dollar values, right? So we are not saying that Benjamin Franklin did not do all the ROI work to prove that an ounce of prevention is worth a pound of cure. He just said, rather than waiting until the fire is burning, what if we prevented it in the first place? So ripping the Band-Aid off here, I wish I had a whole bunch of evidence to say that yes, everything is exactly, 1 to whatever that would be, 16. That's the ROI. Unfortunately, for better or worse, it's an extremely high bar for an intervention to be cost saving. It is possible, and in fact, plausible and quite likely, very, very common for something to be very, very effective at preventing disease, but not actually have a compelling ROI case. So just as what I mean when I say this, I just was working recently on analysis of an upstream juvenile justice intervention. This is not in Idaho, this is elsewhere. It resulted in an 88% reduction in juvenile justice system involvement, basically getting arrested and going in front of the court. A 2/3 reduction in juvenile probation, 68% reduction in juvenile probation. I am extremely confident in these numbers. This is extremely good data, really good study methods. This is great. If we saw these numbers in a program I was involved with, I would be doing backflips. This is awesome. And so what did we see when we calculated the ROI is that it is -13%. This program is fantastic at achieving amazing results. This is a really, really, really good study that, not to pat myself on the back too hard, I'm just trying to emphasize, though, that it's not, we didn't see an ROI of -13% because these numbers are bad or something like that. We saw it because it's really, really hard sometimes to be cost saving. And I'm going to go into why that is during the rest of the session here today, or some of the rest of the session today. But I did want to say that one thing that is challenging is that it's really hard to make the case for a program using ROI when that ROI is negative, right? It's tricky to go up in front of a funder, whether that's a grant funder or your boss at an agency or a legislator or whomever and say, look, you got to give me more money because for every dollar that I spend, I save 87 cents. To me, that's actually fantastic for a variety of reasons, but it's not a great way to make a case using ROI if that ROI is actually negative. And I'll go into why I think it's fine, but just I do want to like lay out this juxtaposition here, right? I don't want us to only go into this thinking we gotta do ROI because we gotta make the case so that we can do like advocacy work or something like that. So just a little bit of sort of self-reflection. I'm going to open up a poll here if I can figure out how to do that. But I'm curious what you in the audience have been interested in using ROI for. Select as many of these as you're interested in. And I added in a couple to the poll here towards the bottom. If this poll is not coming up, let me know in the chat. It looks different for me than for you. But go ahead and add your responses here. What have you been excited to use ROI for?
And for our participants, can you please let me know we've hit the launch poll button? So it looks like I see a few folks joining. So again, Max, it looks different on my screen as well. But oh, I see we've got responses coming in.
Coming in, yep.
All right, all right.
Shoot. That would have helped for me to put up the rest of the questions. Sorry about that. You'll see 2 questions.
And Mac, if you
All right.
like, I don't want to do a lot of transition of screen share, but I could share my screen so that she can. I don't know if you can see the responses coming in. Can you see those?
I can see them. Let me see
Okay,
if I
perfect.
click.
You're fine.
If I
You're
click
fine.
end poll, if you have anything ready to submit, just click submit if you can. I'm going to click end poll. I'm hoping that's going to pop the answers up. Results. Does that pop it up on the screen for us? Okay. So what I'm seeing when I look at these is we're generally looking at ROI. For what we're not doing it for is because someone asked me to, it sounded cool, or because I came to public health to make money. This is great for me personally because I've always said anecdotally, like no one comes into public health to make a ton of money. So this is wonderful to just get some anecdata about that is the case for this group as well. But the most common response was advocacy in pursuit of more overall funding or evidence-based pursuit of sort of specific targeted funding, right? To be able to go to a funder and say like, look, public health is a great investment because we have a nice ROI. Or this specific strategy is really effective. Look at the ROI that we can get from it. So that might be related to that specific juvenile justice program that I put up there. And I'm not really able to see the short answer questions here. Desmond, can you see the short answer responses?
I can see how many have responded, but it's not giving me the
Weird.
actual. Yeah,
I'm
that's
sure those data are somewhere. Desmond, if
we'll
you can
find
figure
them.
out where they are,
I will get on it.
if you could use them for it, just interrupt me when you can figure out where they're stored. But
Yes, sir.
let's sort of move forward with that in mind, right? That we're thinking about ROI because we think it'll be a helpful way of making the case that our program works, and that because our program works, we should continue to invest in it and invest more in it. There is also this doing something versus doing nothing, or if you have a menu of options, which value meal should I choose? The hamburger, the cheeseburger, or the chicken fingers? That is an extremely popular reason for doing let's just loosely say ROI work among academics, among economists, among sort of that group of folks. I've seen it less commonly sort of in practice, but economists really like doing an analysis that compares the effects and the costs and the benefits of 2 or 3 or 4 different ideas to tackle one challenge or to meet one goal. That is really, really popular. It's what you spend a lot of time learning about that when you learn ROI. And I just don't see it quite as often in the field. So I'm not going to focus quite as much on that today, although I will talk a little bit about it. So moving on. Let's talk it through what it looks like when we see sort of like a best case scenario for ROI. What is when we think about like, I'm going to do this ROI, I'm going to get these great data and we're going to be able to share them and it's going to look awesome. What does that look like sort of in practice behind the scenes under the hood? There are a few programs out there that have really nice ROI evidence. Meaning not just one study, one place, one time, but well-performed, consistently replicated, and widely published, roughly easy to find if you just Google the name of the program and ROI or cost effectiveness. One example of this would be parents as teachers. According to IDHW, this is done in all 7 health districts here in the state of Idaho. If that is not accurate, I'm happy to report that I'm just the messenger on that one, but this did seem, at least anecdotally, like something that was done in all 7 parts of the state. So what experts say, an independent cost-benefit analysis and found that it is $4,300 per child from higher test scores and various other things. So how we interpret this is we say $1 invested in parents as teachers will return $1.23 in savings. So parents and teachers has an ROI of 23%. Notice the way that you translate between that, $1 invested equals 123, whatever, is basically you just subtract 1, right? What is the percent gain on your investment there? I'm not going to spend a ton of time going through the formulas on it. If the numbers are scary or intimidating or confusing, please don't worry. The main point here is just to be familiar with both of those, right? Sometimes you hear it said $1 of spending in this area yields this many dollars in return. Sometimes you see it just as a percentage, right? The ROI of this program is blank percent. Just as a little bit of a reflection here, absent any comparison, it's a little hard to make sense of what that means. But I guess just as a comparison, think about your own whatever checking account, savings account, 401k if you have one, whatever vehicles you use to store money, if you have any, if you have any money that we're storing amidst all our other priorities these days. I would love to have a savings account or a checking account that paid me 23% interest. Parents as teachers, in theory at least, would be a better, more efficient way of saving than just putting our money in a checking account, at least in terms of value to overall society. So again, that's what we're talking about when we talk about ROI, is that sort of percentage relative to what we could get if we took the money and put it in a bank or in the stock market or whatever. Nurse Family Partnerships is another program that has really a large quantity and with high quality evidence. What does the evidence say about Nurse Family Partnership ROI? I'm formatting this in the same way, so you won't see it exactly written word for word on these 2 blurbs that I'm shot up on the screen here. $1 invested in Nurse Family Partnership will return $2.90 in state and federal cost savings. That means that Nurse Family Partnerships has an ROI of 190%. So previously I was saying I would be pretty excited with a 23% return on investment. 190% is unheard of in a normal financial setting, right? I don't know many of us who've earned 190% on many, if any, investments in our life. We could be very successful investors if we earned that type of return. So again, I'm sorry, Nurse Family Partnerships, according to IDHW, is performed in Panhandle and Southwest districts. If you are from a district that does a Nurse Family Partnership and doesn't do it, let's chat with IDHW why you're not up on the webpage. And hopefully Panhandle and Southwest districts are now aware of the effective ROI of their nurse family partnership programs. So just as a group reflection, and we can feel free to unmute and either drop into the chat what your answers to these questions are, or unmute and we can talk through some of this stuff. I know just the format of these sessions means that it is a lot of talking from me to you, but I am trying to make this as helpful as I possibly can to you as practitioners. So let's chat through some of these. So how did that come across, right? If I say the ROI in this program is 23%, do you need any more information? Are you comfortable with that number just as is? Would that alone be, and the answer to some of these might just be yes, right? Would that alone be okay for that goal that was most commonly reported of, I'd like to use it sort of for advocating for more funding? Think about, for those of you who asked, I want this to make decisions between two programs. Like, should we take what we're doing as parents as teachers and shift it into nurse family partnerships? I know that's not exactly how it works, but this is kind of how the ROI evidence ends up laying out. So, and sort of as a corollary question or related question, are there other organizations in the community who might be interested or motivated by these estimates? Right? Are there others you're working with? You know, rather than sharing this with the state legislature or a grant funder, right? Could we take this to the PTA and talk about how awesome Parents as Teachers is? And you know, could we take it to someone else?
Well, Mac, we've got a few responses
Thank
in
you,
the chat.
Carol. Yes. What board members, excuse me, what data was used? This is one of my most favorite things. I promise I did not plant this question, so thank you very much, Carol. As a lot of times when we're presenting stuff like this, it's really hard to present that top line, right? 23%. We're doing great, and not get into sort of get right into the weeds of it, of like, okay, well, how did they count this, and where did these data come from, and whatnot? Because if we are using 23% sort of for advocacy, it's hard to do advocacy with granular methodological details. So one thing that I've done a few times is basically create two reports, right? We have a slide or like a one-pager that might look like what we just put up on the screen. A couple logos, a site, all the relevant citations, and a big number that says 23. And then you have Appendix A or wherever that's 2 to 8 pages long that has all the methodological details in there. Sometimes what ends up happening is that people want to know a very, very, very specific thing about it. And either you are the messenger and don't know, the paper wasn't well written by the academic expert, and so it's not in there. It's just hard to answer that question. It's also hard to accurately predict all the time what that person is going to care about. Are they going to care about how we counted, how we measured things? Are they going to care about, was the data from pre-COVID or during COVID? Are they going to care about, was it from California, as we'll talk about later in the show, or is it from here in Idaho? All these things are really, really important. I'm loving these things that are coming in the chat here. I swear here that I'm not planting these things, but yeah, having someone outside your organization, or like just some external person that can come up with this stuff and have some credibility outside of this is a biased estimate or whatever, can sometimes be helpful. Not always, but can sometimes be helpful. Yeah, let's see. It's a hard copy of the studies that determine those. Yeah, so we will get, I can circulate those and I can incorporate them into I can figure out a way to incorporate them. Just as a spoiler or sort of plug for the next session. The eagle-eyed among you may have noticed this for Parents as Teachers. Let me see if I can just highlight here. This 2004 study conducted by Washington State Institute for Public Policy found that this Washington State Institute for Public Policy has an incredible repository of benefit and cost estimates. And I'm not stealing all the thunder from part two, but if and when you are interested in finding a benefit cost study or an ROI of one specific program, Googling Washington State Institute for Public Policy, name of your program, ROI is usually a nice place to start. They don't have everything, but they've got a lot of stuff. So usually what happens is this group compiles a lot of different studies to get kind of whatever pedantic here. They didn't actually conduct a study per se. They did what's kind of called a meta-analysis, or bringing together other studies to calculate these things. So yeah, a lot of times, even though it doesn't seem, let me rephrase. Even though sometimes it can feel like really wonky and like you're getting really far into the weeds on this stuff, a lot of times you do need a lot more information either before using or definitely before presenting, because a lot of times you do get questions just like this that are really aimed at like, okay, where is that study, and can I get a link to this study, and how did they count this? And it's really, really, really critical to be prepared for all those things. So it is usually helpful to have all those references available at your fingertips, so that you don't have to sort of sputter through like, oh yeah, we'll get them for you or whatever, like I just did. I do want to put another plug in here to think through this piece of it too, right? Even if you are not, even if you're really excited about using ROI for advocacy purposes, it can also be motivational in a sense, right? If you can go to your parents as teachers, staff, your parents as teachers, partners, the next sort of stakeholder meeting you have, and say, look, the work you guys do is really important. It saves money. It saves whatever you do, lives or prevents disease, whatever, and it saves money. It might be useful in that context, even if it doesn't get you an extra dollar in allocated funding or whatever. So I kind of already ripped the Band-Aid off a little bit, and sorry to keep belaboring the point, given that I said I'm ripping the Band-Aid off here, but there's more Band-Aids that we're going to rip off. But this is the realistic case, the hard truth, whatever, is that only about 20-ish% of preventive health services are cost saving. So I'll say that again, because I think it's a really, really important distinction for us today. About 20% or less of preventive health services are cost saving. So I know not all of us do preventive health services. A lot of us work upstream and do a whole wide range of things, focused on the social determinants of health or other health determinants. But when we talk about really, really, really non-controversial, popular preventive health services, that's really anything that is, anything from a mammogram to a colonoscopy to smoking cessation, whatever we want to say in terms of a preventive health service, that category of services, 80% of them are not cost saving. So the goal, is the goal actually cost saving, is what I think I want to talk through today. So I'm asking you to basically take two steps with me here. One is to go from ounce of prevention is pound of cure to actually an ounce of prevention is worth like something less than an ounce of cure. I don't know what the exchange rate would be, a half an ounce of cure. Is that okay? Should we just stop preventing things, right? Are we really trying to get to cost saving, right? An example here is I've never had a flat tire when I'm driving around. So having a spare tire for me has never been cost saving, right? This is actually true. As of today, for me personally, I've never had a flat tire. Whether that's due to luck or something else, like I don't know. But for me, I've never had a flat tire. Therefore, all those spare tires that I bought every time I buy a car, every time I buy a used or new car, it doesn't matter. You're always buying a spare tire, with a few exceptions, I guess. Um, I'm wasting money. I didn't need that spare tire. I've never needed it. Across a population, it still might not be true, right? Because this is according to Discount Tires, getting a replacement spare tire, a replacement donut for your car is 50 to 100 bucks to buy at retail. They're included on every single car that you see on the road. So even when we, drive on a road trip and you see 2 or 3 cars over a few hours with flat tires, every single car you see has a 50 to $100 expense on it for a spare tire. It's like, it's not free, but it's not that expensive to call a tow truck. It's not financially possible all the time. I'm not saying everybody just has an emergency fund for tow trucks at their beck and call. At the same time, this is the exact thing that we're talking about when we talk about a preventive health service not being cost effective, right? From an ROI perspective, if we demand cost saving, as we just proved, like having a spare tire is not cost saving. From an ROI perspective, we should remove spare tires from cars. But I don't want to. I wouldn't be surprised if there's a lot of people on the call who feel the same way. It feels right to have a spare tire. It feels right to have this. I'm okay, right? Investing in that preventive car service or preventive asset resource, whatever, even if it is not cost saving. In short, there's financial and non-financial considerations, right? It feels good. I might not have money to call a tow truck if and when I get a flat tire. I might not have the time to wait. I might not be in an area where I can. Whatever the reason is, there are non-financial considerations. So what non-financial considerations are important, right? Our values, those types of things, our preferences, our ability to respond to cure the thing that we're trying to avoid, trying to prevent. So let's channel this thinking for public health. Right. So if we are saying actually our intervention is not cost saving, what non-financial considerations are there? Right. If we're saying it's not a cost saving intervention to do this preventive health service, and therefore we shouldn't do it, we're really ignoring all of those non-financial considerations. And the inverse of that would be true as well. If we're saying this is a really good financial decision to do this program, we should do more of it, we're kind of giving short shrift to those non-financial considerations as well. So I do want us to be careful and purposeful in using ROI. And I'll get more specific about that here in a second. I'm not going to spend a ton of time on this because it's a little jargony, but basically when we talk about cost saving means it improves outcomes by so much that it actually results in decreased costs. So the benefits are greater than zero, and in fact, the benefits are greater than the costs. That's the only time where we will see an ROI that is positive. There are many instances where something is called cost effective, meaning we see benefits that are greater than zero, but the benefits are less than the costs. So the ROI will be negative in that case. There's also some interventions that are cost worsening. It costs money and doesn't improve outcomes. We're not going to talk about those really at all in this context. So when I talk about the non-financial considerations and why we should give them special attention when we talk about ROI, it's really related to this, is that there's really a couple of different ways. Two might be oversimplifying it, but there's multiple ways to assess whether a program or policy works. We're talking today about the appealing to dollars and cents side of the equation. This is really most effective, though, when combined with the non-financial considerations, meaning the people, right? The human side of this, the human story. Ideally, we really need to be doing both, but this is getting us more towards sort of a communications and a strategy side than the ROI side. So I'm going to keep us moving here because I'm already running a little bit behind. So really, I don't want us to be using ROI solely for marketing or lobbying or advocacy type of stuff. In theory, our resources are limited, so we should be seeking to maximize the impact of every dollar we receive. And ROI can help us do that. I think ROI is best understood as an ancillary or additional benefit to providing the service and getting our intended result, right? So in addition to saving lives, we also save money. So it is really nice as that ancillary or additional secondary number that you can put up on a piece of paper accompanied by the stories of how this works and why, the stories of this program's impact. And a lot of us already understand that, but I just want to like really drive that home because again, we saw 0 people say, I want to look at ROI because I got into public health to make money. Tailoring our ROIs to the audience here. This is one of the major reasons, if not the most important reason, why a lot of ROI analyses show that something is not cost saving. If we are going to do an economic analysis, we have to make sure that we are tailoring our findings to pertain to the correct audience. So if I do a whole ROI analysis and talk about the value of this public health program because of how much it improves high school graduation rates, and then walk down the street to whoever it is, Anthem, Cigna, United, Blue Cross, any of these people, and say, oh my gosh, you guys have to give more money to this because look at how many additional high school graduates you'll get. They may be swayed from a human side, but they may not have the interests that we want them to from a financial side. If they're a privately held for-profit company, they've got a quarterly report to issue. They've got targets to hit. They have to look at their costs and their benefits. An additional non-financial consideration may not be plausible for them. Also, likewise, for a state Medicaid office, not disparaging anyone in our state Medicaid office, but they have a budget that is set by the legislature. They may not have the luxury or ability to look at non-financial things that aren't on their budget. So a really, really, really important challenge in public health is that oftentimes the costs and the benefits of a program are not aligned, right? I'll talk a little bit more about this later on here, but I just want to put a plug in here to just think about who is paying for your program, who is paying for the work of the program to happen, and who is benefiting from it financially, because they are very, very, very often not the same entity. And it's not that there are bad people. It's not that there are bad people who work in this office or that company. It's that we have realities of our jobs, or we have realities in our lives, whatever that might be. We may not be able to support in investing in something that does not benefit us in both financial and not financial ways. So without any further ado, let me get a little bit into the literature on this stuff. And this is really the main sort of value, this is the main area of the presentation where my goal is to give you guys specific concrete resources that you can use if you're looking to use ROI sort of for advocacy or sort of proof of concept purposes, especially if it's more sort of broad scale rather than specific targeted stuff for your specific targeted program. So a little bit of a drum roll here. I know this is a little bit of a busy page, but the reason that I'm highlighting a couple different things, we'll see in a second here, is because there isn't one number. And so I'm going to give better links to all these. I mean, you can copy down this link here if you want, but I'm going to give user-friendly links and QR codes to all these here in a second. But just focusing on what these actually say for a second. So this first study, I was actually one of the authors of this, but it looked across all of the literature in the public health literature and converted it all into sort of what does $10 of spending on public health buy. We see, these are the outcomes from it. And depending on how you want to value those, the ROI number will vary. So if you are looking for something that is like, I want to show that our county, district, state, nation, whatever, spending on infectious disease is really important and has a strong ROI, $10 of public health spending per capita spending, will result in a decrease in infectious disease morbidity of 7.5, roughly 7.5%. So I would love to get into all the methodological weeds on this. We might have to schedule a different session to do that, just because it's gets into wonky econometrics that and I'm not sure how many others really enjoy talking through. But if you're looking for sort of a specific, like this amount of spending equals this type of population health outcome, that report that I'll highlight in this space on the next slide so you can access it, has these findings. A different study, this was a meta-analysis, meaning you take a whole bunch of studies that have already been done and you combine them all to get one overall number. It was reported in the British Medical Journal, so it's more of an international context, which makes it a little bit tricky to apply here in the US, given our public health system. For every $1 invested in public health, $14 will be returned to the wider health and social care economy. Remember, our parents as teachers ROI was 1 equals 1.23. So this is 1 equals 14. So we're talking about like 1,300%, more than 1,000%, tenfold return on investment. Yeah. So again, it's a pretty ambitious number. An even more ambitious number comes from California, which I am highlighting here because there is a reality that if we want to use this number, the reality is this comes from California. And this doesn't come from California because of anything about California, other than California has awesome data systems to do this type of analysis. They have really detailed data on how much some of their public health services are spending, some of the outcomes that are linked to those expenditures, and all this is done at the county level. Frustratingly for me personally, I'm not able to access those data. So this was done by a economist at Berkeley, but this was published in the American Journal of Public Health. You can see here, $1 invested in county health departments in California results in an ROI between $67 and $88. Again, that's like 8,000% return on investment. Hugely, hugely high. Right now, our savings accounts are making like, whatever, 5%. So if you would like to download any of these references, any or all of them, whatever, those bit.ly links are the links that will take you to the full link that I showed 2 slides ago. You can also scan using your smartphone any of these QI codes. On my Scouts On or whatever, all these are, you're not going to be taken anywhere commercial or whatever. These are all just links directly back to those resources that I just talked about on the previous slide. And I suppose this is being recorded, so I can't say this too much, but if you're having any trouble accessing them, if they're behind a paywall or whatever, feel free to reach out to your friends at Boise State University. We have access to scholarly publications, and for our colleagues when we work together, we can provide resources to our colleagues. So if you need some of these, interested in them, let us know, and we can almost certainly get them for you. So that's what the literature says, and you'll notice I put it into sort of 3 different buckets because of how enormous that spread is. I don't want to tell you that the literature says the ROI is blah when the ROI is blah. So it's hard to tell you what the literature says. It is somewhat easier to tell you what the literature does not say. The literature does not say that we're spending too much on public health, or we're spending more than we used to be, or that spending is ineffective at improving health outcomes. There are some limited exceptions there, or that spending is inefficient or a bad investment. And again, limited exceptions there. One of these limited exceptions here, actually 2 of them with, I guess, apologies or whatever, I'm responsible for them. One example of public health spending is an inefficient or bad investment is that we used like some of the hardest methods we possibly could. So we tied both of our hands behind our back and said how good how great is the public health system, or how effective or ineffective is it. We use the most the methods that were going to make us look the worst, like under the worst possible assumptions, the absolute worst case scenario. How effective is public health spending? We use really nice data for it. And again, I'm happy to share these resources if it's of interest. And that's when public health spending starts to look inefficient, but barely. I mean, we're talking about you'd have to, when you compare it to a clinical care ROI or cost effectiveness we compare extremely well. It's only when you think about like, well, we're not technically cost saving, whatever. We're like getting really into the weeds here. So what I'm basically trying to say is we can feel comfortable because I think we are doing justice to the academic literature on this topic to say that public health has an ROI. It is not 16 to 1 or whatever, ounce of prevention equals pound of cure. But it is an effective investment, and it's effective at improving health outcomes, our public health spending. So to the extent that we were interested in coming to today's topic to get evidence that could help us make the case that public health spending is effective and is a good investment, I draw our attention to these three resources here. I'm not going to say again that there's no human side of this story that needs to be told, that there's nothing else to consider besides this. And I also won't even say that you will never, ever, ever find a study that says public health, whatever, was a bad investment or whatever. But you can find counter examples to a lot of things. The holistic summary of the body of literature that currently represents our knowledge on the ROI of public health is very positive. And I think that is something that is worth noting here, especially given the complexity of the previous slide, which I said it's this wide, the range of ROI. I'm saying on this slide, but I promise it's not, this range over here that's so bad that it's actually negative, or that we've seen such massive increases in public health spending that we're getting to really the flat of the curve, the part of the spending that's really not getting us much more in value. So I'm not going to spend a ton of time on this today, but why don't we have better ROI evidence? Why can't I tell you what the number is? Why am I being so effusive and refusing to answer the question? It's because it's hard. It's really, really, really hard to do this research. We barely even know how much money we spend on public health. It takes an incredible amount of work just to know, using a really bad definition for what public health is, how much we spend at a county or a local level on public health every year. Right? So if we don't know how much we spend on public health, we can't possibly calculate the ROI on it. And if all we know is a total number for what we spend at a county level, we can't possibly attach an ROI to that. So it's really, really hard. So people ask different questions. They ask for ROI on everything versus one thing versus a tiny part of one thing versus multiple things under this condition and for these people at this time. The other answer is that the ROI actually does vary. And the best example I can give here is when I was in a different role, I worked as part of the COVID response, setting up mass vaccination sites. And for a part of our experience setting up mass vaccination sites for COVID, we set up a vaccine site that eventually served about 1 million people, well, over 1 million people, because there's a big news story celebration of it, incredibly efficiently. We were just cranking people through these sites. With safely, of course. There's nothing like nefarious going on here. For a different part of that response, our goal was not to crank 1 million people through. Our goal was to serve the hardest to serve. So those two initiatives are going to have vastly different ROIs. Because for that latter initiative, we might consider it a success if we vaccinated like 1 or 2 or 3 people. If these people are the hardest to reach in the hardest to reach populations and the most underserved areas, our biggest priority population, serving 1 or 2 or 3 might be the goal of the program. The ROI of that is different than the ROI of cranking 1 million people through a mass vaccination site. So it is okay for there to be variation in the numbers that we report in terms of the ROI for public health programming. So we're starting to wrap down on time here. So I do want to put a plug in to please put any questions or comments you might have in the chat. I am going to go a little bit into the details here on I'm going to go just a little bit into the details here on whether and why we can expect public health funding to be responsive to our ROI calculations and numbers. So there are a bunch of reasons why we think ROI should help us advocate for more funding or make the case for more funding, I should say. One of which would just be like, we live in a country that celebrates the free market and relies on free market principles to help address a lot of the different needs, challenges, societal goals we have. So free market economics suggests that something with an ROI of 23%, let alone 8,000%, should be properly funded by the private sector. But that's not the case. So there are challenges, right? All of these challenges here are centrally critical to why we don't see more investment in public health. But I want to talk today about this wrong pocket problem. The wrong pocket problem is what I was talking about earlier, where one agency pays for something and another agency or entity or system or person benefits from it. An example of the wrong pocket problem comes when we prevent a disease, right? When we prevent a disease, that person does not get sick. So whoever paid for that prevention activity paid, put a lot of resources, effort, serious stuff into preventing that outcome. Excuse me. What happens when someone gets sick? Well, oftentimes they have to go to the hospital. They have to be treated by doctors. They have to have tests. They have to be, prescriptions, whatever the case may be. That's a lot of money that is usually paid for, at least in the US, for among people that have health insurance, by an insurance provider, right? So if a public health department prevents a disease, a third-party health insurance provider saves some money, in a very oversimplified example. So when we talk about ROI in public health, we go to a state legislature and say, wow, look how much money you can save. You can save 23%. Or the equivalent, if we invest in this area. Even if a legislator is really excited about that and you got them aligned on vision, on values, on priorities, they have the money, there's no corresponding benefit to their budget if they save the 23%. The corresponding benefit in the budget is seen in the insurance providers or the insurance payers budget. And to make matters a little bit worse, is it's also not even really seen, right? Because we don't actually know when that disease was prevented. All we know is that the program happened, and then across the population, disease rates went down. So it gets extremely hard when the costs are borne by some and the benefits accrue to many. You get what's called a tragedy of the commons situation. So I am going to skip ahead here back to this slide. Sorry, I went way too far. Back to this slide, which is sort of after I told us a little bit about ROI, the piece that I put a plug in for, right? That ROI is part of this equation, and that ROI can be effective when it is lumped in with the non-financial considerations. Again, nobody came into public health to make money, at least among our group, but also among most groups that you talk to. That said, public health does save money. The work that we are all doing, the work that you are doing in your organizations, in your communities, is preventing disease and is saving money. So to the extent that it is relevant, we've been provided with resources today to demonstrate that to your funders, to your stakeholders, to the people on your teams who are doing this work, right? Who may be burnt out by the last 3 to 4 whatever years now, who may be overworked and underpaid. It may be helpful to just do a quick logic check with them and check in and say, the work you're doing to deliver this program is saving lives and saving money. To the extent that you're working in that area. I'm not trying to say everyone in public health always saves money and always saves lives all the time. But I think where I am going a little bit with this today is the types of evidence that we've talked about here is pretty good at making the case that at a system level, there's an ROI case to be made for public health. It is not every program. It is hard to be cost saving, so a lot of them aren't. But public health can and does save money and save lives. Just not in every single context at every single time. So that is why, one, it's important that we're not doing public health work for the purpose of saving money. We're doing public health work for the purpose of impacting lives, impacting communities, saving lives, preventing disease, whatever it may be. So I don't recommend going into this saying that the only evidence I'm going to present is ROI, or that I'm going to make the case for my program because we care about ROI. We make the case for our program sometimes in a way that sometimes includes ROI, is I think a less fun, but probably a little bit more realistic way of thinking about this. So we are going to be continuing this conversation. The last QR code, second to last QR code I will put up for today. In the spring, we are going to be talking about finding your program's ROI. So if you've heard all this and you're still motivated, you're still excited to calculate the ROI for your specific program or your agency or your body of work, got good news. We're going to talk about more of that. Part 2 is going to be held in March. We will talk about that Washington State data set. We'll talk about some of the more nuanced considerations. Again, this was maybe like the 30,000 foot level. We're not going to get into the weeds level. It's only an hour long. But we will talk a little bit more detail, a little bit more granular about ROI again in March. We will have a couple other continuing ed lectures before then, so please keep an eye on your inboxes. And I also did want to put a pin in our minds. We do offer a online Bachelor of Arts in Public Health, and we have some certificates, more certificates and more certificate news to come soon. But with that, I will stop sharing my screen and return here. If there are any questions, reactions, comments, welcome you to either unmute, raise your hand, drop into the chat. I believe, if you'd like to do something anonymously, if you're embarrassed to raise your hand or whatever, send something to Desmond and he can read it out. So then no one will know who asked the question. But really, we're all friends and colleagues here. Just raise your hand, unmute, whatever.
Absolutely. Everyone, please feel free to unmute yourself and you can go ahead and ask the question, or you can share within the chat and we can present it that way. And while we wait for questions, I just want to thank you all for
I don't want to let
attending
us sit in silence for too long, but I'm curious if anyone has had any experiences calculating or using ROI.
Okay.
You can either reach out here to me or just unmute and talk to the group.
All right. Matt, can you hear me? Is my audio coming in okay?
Yeah, my audio shut off and I just noticed that. Sorry, guys.
That's all right.
Was I just talking over everyone for an awkwardly long amount of time?
That's all right. Joanna, can you give me a thumbs up if you can hear my audio? Okay, you can hear me. All right, perfect. Just while we wait for questions to come into the chat, Dr. McCullough, thank you very much for then. This was outstanding, and you guys, I'm sure we're gonna have even more people here for our part 2 on March 12th. So thank you very, very much, and thank you all for attending. I just want to give a personal thank you to you, Mac. Now I can tell my wife like why she should keep me. Like I'm kind of like a spare tire. You don't need me now, but you never know when you might. So I think we all can take some motivation and inspiration from that. But again, thank you all for attending, and please join us next month on Tuesday, January 16th at noon, where our very own Dr. Sarah Tage will have a session on exploring best practices that local communities can adopt to help promote the health of rural and aging populations. So you're in for a treat. Great session that we're expecting there. Again, if you have any, questions, comments, concerns, please put them within the chat here. But Mac, just many thanks again for an excellent presentation today, and thank you all for attending.
Thank you very much. And just to make one final ask, there'll be an evaluation feedback opportunity. Please, if you can, just fill that out and even just numeric ratings are super helpful to us just to know how we're doing and what changes we can make to make these even better in the future. So thank you very much, everyone. Appreciate it.
Absolutely. Thanks all.